Welcome to Vatech America's monthly webinar series. Today is September 2nd, 2020. This is the 12th edition of our webinar series. We started back in April. I am Jim Mayer, Education Team Manager with Vatech America, broadcasting live from my home office here in St. Louis, Missouri. As always, I have the pleasure of coming to you with my coworker, Paul Satone, out in Las Vegas. Welcome, Paul.
Thank you, Jim. Great to be back for our monthly webinar. This should be a great part 2 webinar. I'm really looking forward to this one.
Yes, we last month we brought on Sal Rodas with Sleep Architects. We're doing a 3-part series over dental sleep medicine. Last month was CBCT and sleep disorders. Paul, tell us a little bit about what we're doing today.
So today we're Dr. Ataii and Sal Rodas are going to be discussing the business of dental sleep medicine. So we'll talk about they will talk about the patient workflow. We'll talk about sleep and digital dentistry, and they'll really dive into that. And they'll talk about really a question we get asked a lot, which is about insurance. So they'll dive into that topic as well concerning sleep treatment and some great practice growth strategies they have to share today.
Right. Other thing, so this is a 3-part series. So next month, we're bringing Dr. Ataii back to talk more about clinical applications of CBCT and sleep disorders. So that will be the 3rd part of the series on Wednesday, October 7th. So I hope everybody can join us for that. Paul, throughout these webinar series, we've actually also started another series that is on Fridays. Our new learning series, we're calling it, or we're calling it Fast Track Friday.
Right. Yeah, so Fast Track Friday, we're going to do our next one on Friday, September 18th. So we've modified it a little from the past one. Instead of doing 3 sessions, we're going to do 2 2-hour sessions. And we've kind of organized the information and added stuff in there. So really looking forward to putting this next Fast Track Friday on.
Yeah, first session being, for doctors and staff, improving image quality, both 2D and 3D, talking about dual scan protocol, scanning cast models in CBCT, identifying patient movement, really just making the workflow easy, taking off the that. And then session 2 is going to be delving into more of the 3D software for case planning, looking at 3 or 4 different cases, all through different clinical applications. We also have some radiology reports we're going to review. We get the question a lot of, when do I send my scan to a radiologist? Well, we actually have a data set we're going to look at, and we're going to have the radiology review that we can go through with the audience as we progress through that on Friday, September 18th. So hopefully everybody can join us for that. Paul, how does this whole education series come about?
Well, really, we wanted to really have a session and a series where people could ask more questions and get in there and really, kind of dive more into the day-to-day operations and questions that may come up. So they're a little more interactive, I would say, compared to just our general webinars.
Right. So our Wednesday webinars, we're bringing our key opinion leaders in the industry and really delving into more clinical topics and what their knowledge is. And this is going to be more software-based. And Vatech product there. So all these came about through feedback from everybody that's joined us throughout this session. So all different ways to connect with us.
Right. So a couple different ways. Any feedback for any future webinars in these monthly series, please email the sales email address on the screen. Any questions, anything software related you may have questions about, please email us at education@Vatech America. That goes to everyone, and we'll get back to you on that. And then customer support email address as well as there. And we also have, we're also at the handle at Vatech America on Facebook, Instagram, and LinkedIn, and of course our website, vatechamerica.com. So lots of ways to get a hold of us.
For sure. Yep. And we do appreciate your feedback and interaction there.
Yep.
If you're logged on, you should be seeing Paul and I at the top of the screen. The screen below. Off to the right, you have your GoToWebinar navigation box. If you're having any audio issues, click on your help button or just go ahead and do a phone call in. You'll be able to listen without any issues there. This will be a Q&A session towards the end. We're going to go for 1 hour with Dr. Ataii and Sal Rodas. At the end, the last half hour, we're going to go through a Q&A session. So please feel free to chat back and forth with the Vatech education team. We're standing by to answer or direct any questions, but we will be cataloging those questions for both presenters today at the end of the session. Paul, you did talk about this a bit, business of sleep dental medicine today. Kind of here's our topics, our 4 or 5 different bullet points.
Yeah, so we have a lot of information here, and if we can jump into the next slide here. Can you hear me there, Jim? Sorry, my screen froze.
Yes, I can.
Technical difficulties, Sorry about that.
Right.
So yeah, today we'll be talking with Sal Rodas and Dr. Ataii, talking about everything on the screen here.
Yep, so sleep workflow, dental dentistry, insurance is a big one, growth strategies for your practice if you are already implementing or thinking about this. But Paul, let's go ahead and introduce Dr. Ataii.
Yeah,
I'm gonna go ahead and share his webcam.
There's webcam there.
All right, Dr. Ataii, welcome. Dr. Ataii, you are a KOL for Vatech America. Thank you for taking your time out to join us today. In a little while, we're also going to be welcoming Sal Rodas. But Dr. Ataii, you've been practicing dental sleep medicine for the past decade. I'm going to kind of leave it right there and let you do your introductions, and we're going to go ahead and share it over to your screen also. We'll make you the presenter. And welcome, and thank you for joining us.
Thank you very much for having me. And it's always a pleasure to not getting on a plane and at least being able to see everybody via internet. Those of you who may know me, you know me as a person who's been advocating sleep and dentistry for GPs and specialists. We're talking about airway health and the use of digital technology, may it be cone beam, may it be just any modern way of us being able to talk to our patients. Because as I use the word modern, today's technology is moving so fast. And at the time when I was going through dental school, cone beam was only used at that time for specialists. As a general practitioner, as you know, we start to dive into airway management, moving teeth, clear aligners, even restorative, and some of you are dabbling in full mouth restoration. So a lot of articles, a lot of publications that I've been involved with talking about what we're seeing as the trend. And the trend really is not just what we're experiencing of the obviously the masks that everyone's wearing. As you can see, I put it on my kids and family just to make sure that we're all following orders, but really the airway. What happens neck up being our department? What happens when the collapse of facial contours really starts to create malocclusion? Why? Patients grinding, bruxing, sometimes even wearing down a teeth or teeth being overlapped. All of these creates a malocclusion, which at a later point, patients start to develop a restricted vertical, if you will, and affects what we call now the airway. The reality is the past 10 years, I've been talking the ideal teeth position, whether it's CO or CR, and multiple types of conversations have been, are we going to put it in a central collation or a central conclusion, which is what's, well, teeth on bone. That's where teeth belong. Teeth belong on bone, and most importantly, tongue belongs in the floor of the mouth. When we don't have that, guess what happens? We tend to have a collapse, and you start to see the airway collapse. And to talk about that, talk about patient's profile when it comes to orthodontics, restorative, periodontics, including sleep apnea, they all fall under airway management, in my opinion. And again, the ADA took a strong stance back in 2017, talking about comprehensive dental care and talking about now looking for sleep-related breathing disorders. Dentists are now the only health care providers with this knowledge to provide oral appliances that help patients. So given today's time, given today's climate, given today what we see with the idea of COVID and it being an airborne and airway health that creates this. And whether you have good immunity or bad immunity is really affected on how well you're sleeping at night, which brings us to the conversation of sleep apnea. Because the reality is, prior to COVID, it was kind of the snoring. You know, do you have snoring? Are you snoring? And everybody says that was a trigger word. Yeah, I snore. Okay, now snoring could be your tongue blocks the airway, and that could be apneic events. And let's take a look and do a sleep study. And you know, the idea of airway was a little bit hidden, but then the idea of potentially talking about respiratory and talking about airway starts to come in the forefront given today's climate. So lungs become inflamed, becomes harder to breathe, can lead to pneumonia. I get all that, but do patients understand that we are able to visualize and actually see neck up? Do your patients know that there's actually a process in your practice that you can talk about the risk factors, that we can, you know, patients with poor oral hygiene, patients with chronic lung disease, patients with serious heart conditions, obesity, diabetes, all of these airborne diseases, including poor sleep, including malocclusion, are similar attributes of patients who have obstructive sleep apnea. And now visually, you're able to give them something right away. So let's talk about that in a minute, because you know we want to talk a little bit about our office in the way that we're seeing patients today in today's climate. Well, the reality is, you know, the quick way of identifying patients is, are you a CPAP user? Yes or no? Guess what? If you're a CPAP user and you potentially may have the risk of COVID, you could be passing that to your bed partner, because you're creating what's in your lung that's getting pushed through your body and then gets pushed out. So are you always tired? Are you, you know, falling asleep difficulties, or in a dental chair maybe even, or are you a night guard user, or do you have snoring issues? All of these complications add to this quick identifying airway. Now, I put this Aaron picture because, you know, unless if you're able to do this with your tongue, take a close look what he can do with his tongue. He can actually move his uvula, the back of his uvula, and bring it forward. And he says he doesn't have any problems. He just brings it forward and then he doesn't snore anymore. His girlfriend's happy. The reality is, when we start to see these patients, not all of our patients are like Aaron. You know, 99% of our patients have some sort of potential issues that lead from neck down. And now the impact of users of CPAP, even the American Association of Dental Sleep Medicine is saying, look, you may want to consider oral appliances. Fantastic. Now, how do I get there? How do I get a patient convinced given these times? Because an oral appliance may increase during time of COVID, but does that mean patients are going to accept treatment? Look, if you can't see it, you can't treat it, and you can't explain it. It was when digital x-rays came out. When I saw a little film, I kept telling patients, see that little gray spot there in that little film? Now we have what? A big, huge 32 screen inch monitor to show them what their cavity looks like, and they can see a big old hole in their teeth. That is the key. So when you start talking about CPAP and airborne diseases, no matter how much research is being done, that oral appliance usage will go up. Doctors, you will be the forefront of helping this airway management. Doctors, dentists, all of you are one. Physicians, all of you are considered neck up our department. However, our patients, we have to be able to get them to understand that it's no longer about cosmetics. And as a matter of fact, cosmetic procedures are going to become less, and people are going to be considered about their health. Think about your patients. What happened in July when you reopened your practices? You had a spike. All these patients that were waiting to get treatment done, and all of a sudden you came back July, August, you had a spike. Will that continue? November, December, January, February? Were patients fat or were they skinny? Did your patients lose weight or gain weight during this COVID time? Are they stressed out? All of this could be addressed with a simple visual. And in my mind, talking to patients about money is simple so long as they can understand it. What am I paying for? My health? I get it. I'll go to the gym. Not many gyms are open these days. Oh, I'm going to put myself on a diet. Fantastic. You're working at home? What are you doing all day? Snacking? So when you start to talk about what it means to the dental profession. Economically, dental sleep can lead to a way of not just reopening, but reopening to a spike, which is what's happened, right? I'm sure that all of you dentists who have reopened your practices have experienced a July and August spike in more patient acceptance. So let's talk about some of the communication, some of the tools that we were able to kind of put in place in my practice and maybe give you an idea of what I've been doing. Yes, that's what we were supposed to wear, but that's not true. We wear our gown and mask just like everybody else. I just thought it'd be fun to show what the fears were of what we're gonna have to wear. The reality is, I very quickly talked about pre-screening patients and really quickly posted on our website, and you can see it, that we utilize CBCT technology. We can do an airway analysis and see how you're breathing at night. Talk about why airway is important in your lungs. Why is it important in today's climate as a dentist for you to be looking at someone's airway? Well, what happens when your tongue blocks the air and you're getting apneic events? You're getting no to little oxygen. Well, your immunity can potentially be compromised, could it not? If you're not getting enough sleep at night and you're not getting enough rest, patient, and you are fatigued, will that increase your chances of potential having a susceptibility of catching this virus or any kind of low immunity? Absolutely. Now we have an open conversation. It's more important now to talk about CBCT as a part of our treatment planning process. It has to be. It's always been, but we've been worried because, oh, the radiation. I don't want to expose my patients too much. Look, I have an 8-year-old who's got severe issues with asthma. I purchased my CBCT specifically for my 8-year-old. Why? He's 13 now, and guess what? I've been able to manage his airway by being able to see with a short scan. And I'm not worried about the amount of radiation, because we'll talk about that on the next webinar, about the clinical applications of how much radiation are you really getting in what's called microsieverts. We'll talk about that, and I'll relate it to amount of bananas. Some of you have heard me say this before, of having one banana is amount of radiation that you get with 1 microsieverts. We'll talk about that, because guess what? Bananas are in the sun. Sun has radiation, does it not? So the conversation piece that we need to talk about is the business effect of patients suffering from sleep disorders. Now, may it be malocclusions? We can just take that subject, restorative, whatever subject line, patients grinding their teeth, wearing down their teeth, every one of these subject lines are a conversation for you to have. Narrow bite, visuals, a photo, an image, a crossbite, a wear down of a teeth, a tori, they see that. But do they see their airway? Because we can talk about the treatment only if the patient comprehends where you're trying to take them. Every photo you see, the before and after, are patients who've been treated for not just airway, but clear aligners, putting patients in the proper occlusion, getting the tongue in the floor of the mouth. Every one of these photos are there as an educational piece. Why? Why should I spend $5,000, $10,000 with you? Right? So when you start to see these patients, again, we're going to get into a lot of clinical on the next webinar. I just want to kind of give you a glimpse of what my hygienist talks about, with the scalloping tongue, with the narrow vaulted arches, with the crowded teeth, with the worn down bruxing of the teeth. All of these are indications of identifying sleep disordered breathing patients to take them to the next level. And most importantly, you've got to be able to have this conversation where you are talking about them, that they are at risk for low immunity and for sleep apnea. Now, all this was featured about utilizing CBCT back in 2017. As a GP, it was an honor that I was on the cover of Orthodontic Practice Journal and talking about oral appliance therapy and using CBCT in addressing combo type treatments. Well, I got a couple of nice emails and I got a couple of bad emails. A bad, I say, because at the time in 2017, some of our peers said that they don't believe in taking a CBCT on their patients. Remember, CBCT is not for you to use as a treatment plan or a diagnosis. It's a visual, just like an x-ray. You would look at whether or not your crown margin is sealed or is it open. Am I able to visualize an airway or is it closed? Because what happens when the patient lays flat on their back? Potentially that blue airway you see on the cover of the magazine could potentially be blocked. Now, this becomes a big problem for some doctors because they are worried about harming their patient by not giving them enough information. Maybe a radiologist needs to read this. Absolutely. I give them those options. So let's talk about that. The workflow. How does it workflow work within the COVID-19 as well as dental sleep treatments that I've been rendering and giving to my patients for the past over 12 years now? Let's talk about that. I know the ADA had a whole process in the workflow of the COVID. I won't get into that. It's taking the temperature, making sure the patient fills out a form of whether or not they've been, had a cold or fever or, the wellness checks. But what I did was I actually wrote a communication letter to all my patients as to what the process is going to be. You're going to be coming in, we're going to take your temperature, and we're going to take care of you and do an airway analysis. Why is that important? Because patient, you have two options. You can refuse, no problem. We still get to see you. We'll take your temperature and follow. But what we're going to talk to you, patient, about is that we're going to have a radiologist actually read this. We're going to have a CBCT specialist read this report. There are things that we might miss. You might have, and you'll see in a minute and again next week, a lot of diagnostic tools that will show you. But the reality is that I'm giving the patient the option to choose, and that option can either cost them $145 to $200, and that could go towards their treatment should they choose, if it's a implant, if it's a bridge, if it's a oral sleep appliance, if it's a full mouth reconstruction. Whatever we are giving the patient the option that now we have this. Why we do this is it becomes an indirect marketing for patients to say, hey, these guys have stepped it up. They've put an HVAC in here that does all this disinfecting stuff. They've put, granted, everyone's wearing a gown and mask. We did that anyway. But what have we done different? We're giving the patient to have their airway analyzed. They're giving a treatment option that, hey, maybe I do need to get better rest at night. Maybe I do need to get better sleep at night. And by simply saying yes or no, I've done my job. If they want to have it read, great. They pay for it and we send it out. And you'll see next week multiple places that'll read it for you and give you some analysis, or they say no problem. We continue with our regular day. Just yesterday, these photos are yesterday, my endodontist came to the practice and he looked at tooth number 13 and said that there is on an x-ray, there's 2 canals. Now, we had taken an airway analysis or a CBCT prior. This patient, we simply popped it up and found out that it was 1 canal, but it was a bifurcated canal, and it was really 1. Now, why is that important? Because he was about to put the file in where I wouldn't dare to put, but he says, I can't see. I says, wait, I have their CBCT. Let me show you. And within seconds, we were able to identify. And this happens on a day-to-day basis. So I've marketed, I've advertised it, I've let my patients know about it. It's a technology that puts me as a GP separate and away from the regular treadmill of drill and fill. So we've put together of how we reopen, how we do our even a video assessment. All of you know some of these processes, but it all leads to airway management. And for me, whether we were staying at home or if they send us back at home or we reopen, my patients are continuing the same process flow. Now, with that, I want to kind of give you a little bit of time to kind of see how we are in our practice utilizing the airway and maybe bring live an actual CBCT that we can show how quickly it is to show the patient their airway. And again, I just want to kind of give you images. This is a particular patient, Kevin, that we'll be discussing next week, and Sal is going to dive deep into this patient's insurance and financials and how we actually make money off of this. But the reality is that for me, without appliance or with appliance, there's a difference. And you can see the green on the left side of your screen versus the blue on the right side of your screen. That shows the airway and the spacing. And that particular airway and the spacing is what's key. So if I can bring my Vatech partners online and kind of put one live, and let's show the doctors of what we're able to see every day on our patients. And then we'll like to bring on Sal for the business and the money part that I love so much as well.
Perfect. Thanks, Dr. Ataii. Yeah, I'm bringing up Paul Satone. He's going to go through a scan with us. And actually, let's go ahead and bring up Sal also, so we can kind of get his input here. And Paul, we can go ahead and see your screen there. And what we've done here is we have an actual 21 by 19 scan, so a really large field of view Vatech scan on a patient. We can see that they are in eccentric occlusion or not on the bite stick, relaxed. And really, Dr. Ataii, you talk about really showing the patient and visualizing and communicating with them a lot on anywhere from what your practice is doing to keep them safe all the way through explaining the process, visuals of photos. But here with our software, we've made it very simple. 2 clicks to measure the airway. And Paul, do you want to go ahead and kind of run through that of, you can learn this very quickly. Anybody can, even our hygienists, our assistants can take this measurements and show everybody, hey, here's what we're referring to.
Right. So yeah, just to kind of demonstrate how quick and easy it is, it really is 2 clicks. So on this, right on our NPR tab, we have our measure airway button right to the left here. I click on that. It automatically, by default, brings up the sagittal window, and then my cursor, it is simply 2 clicks. So in the back area of the hard palate, I'm going to click once and then bring my line down past the epiglottis down there, and 2 clicks, and it goes ahead and processes the airway to visualize and colorize that airway. We can see it on all aspects. I'm going to go ahead and bring it up on the 3D window here so we can see it right there nicely displayed. What I can do here now is take my opacity down if I want to kind of segment that airway alone. There's my colorized airway. We can see the constriction on there. If I rotate it around, it'll show by default the most constricted area and also the total volume there. What I can do now is right click on it, select measurement plane, and what this does is this tool allows me to scroll up and down so I can assess my airway from the top to bottom here. So it gives us that millimeter squared measurement up and down it. We also have the capability of taking screenshots all through this process, so I can just do a region capture here, scroll and get a capture window there. Stores it for me there. I'll bring back up my opacity here. We have different VR coloring looks to this as well. So we have a bone look, grayscale, and also a skin default here. And what I can do here, just as an example, is, if I'm showing the patient for consult purposes, I can slice this right in half. So if I go to my clipping tools on the left, I can click apply clipping and just simply cut away from this image to really give a nice look at that airway in this view here. Maybe I'll do this.
That's actually a powerful tool, Paul, because that's exactly what we do. And then we said, if we can turn our screen upside down or side to side, this is the way you're sleeping at night in your tongue, guess where it goes. And the patients just go, oh, wow, I didn't know that.
Right.
So it's a really good visual of the patient themselves.
Yeah. So that's my
one thing I would add that I think I brought up in the last discussion is, especially for patients that suffer from sleep disorders, most of them are not aware of their disease. In fact, most of them are in denial because somehow they wake up every day and they have no point of reference. So when you use images as powerful as these, you help the patient own up to the disease and make a better informed decision upon case presentation. So this is, from our perspective, a very powerful educational tool to help the patient instantly understand what's happening to them, because otherwise they have no point of reference.
Yeah, absolutely. So a few other tools here. We also could go into our section tab, and I can do a section slice right through that passage there. So what I can do here is bring up my sagittal window, and I'm going to go ahead and click on Draw Curve right on the left here, and I'm going to start right at the tip of the nose and go right through that passage all the way down. Do that one more time. all the way down to the bottom. And what I can do now is I can expand this out right here. So we get our 1 millimeter section slices here, and I'm going to start right at the tip of the nose, and then we can really see all the way through the nasal passage as we go through here. That's another view that we can also view this in. I can double click to expand that, and we can see slice by slice really going through that entire nasal passage and airway.
Yeah, and I don't know if you know this, but another way to understand the condition of the airway on patients like this patient is to do what's known as a drug-induced endoscopy, where the patient is given drugs and then usually an ENT will put a camera and travel through the entire pharyngeal passageway to identify where the patient is compromised. While using this tool, you're basically doing what we call a virtual endoscopy, because you don't have to probe the patient with, this foreign object. If you've ever had it done, it's very uncomfortable. And it gives you similar, if not more powerful data than what you would get with that intraoral camera.
Absolutely. From here, so for instance, we can go and take a look at our TMJ now. So right within the software, we have our TMJ tab as well. And that is a simple click here. It takes us into the TMJ mode. And just all we really have to do here is position our navigation windows over the condyle on each side here. And we can get a great view of the whole condylar area. And we can simply also rotate around that as well.
Mm-hmm.
So this is where Dr. Atai's tough background comes into play.
Yeah, we're going to have a lot of fun next webinar, Doctor. So strap on. We'll be talking a lot of clinical.
Jim, anything you want to add about this TMJ window?
I think, yeah, with the TMJ window, you can go through and change your opacities. You can change it to the MIP to get more of that slab view that we talked about with Dr. Miles, adding that thickness on there. So go over to your windowing. Yeah, maybe change that up to 10 or 20. And then go to your windowing over to the left and change it to MIP. And that's really going to give that lateral medial view of that condylar head.
Right.
And then you do your diagnosis, which Dr. Ataii is going to talk more about, like I said, on the next webinar, and really get into more of the clinical data and aspects of what we're looking for on the medial pole or different things like that. Yep.
Got it.
And I think the important thing to highlight here is that aside from the clinical data, obviously that clinicians are capturing with the cone beam, the power behind these images and is how easy it is for you to get the data and present it to the patient, once again, to get them to better understand what's happening, why they're potentially clicking and popping, why do they feel tired throughout the day. So these, again, are powerful tools.
Right. So just to kind of finish up on my end here, so I've taken a screenshot of each one of these kind of features we went through, and then to kind of sum it up, we have this great console tab, and when we go in there, it displays all of our screenshots down on the bottom. You can see I have a bunch of mine in there. So all I have to really do is I can grab my screenshots and drag them into my window, and then discuss with the patient. You can grab images side by side. You can see all the screenshots below. So we can discuss that there. We have markup tools and things to point things out with. So there's a lot of great features in here. And then also, we do have some videos in here as well. So for instance, we have a disc displacement TMJ video to kind of, maybe we'll pull the image up next to the video to discuss there further on the consult there. So lots of options here to really present really nicely.
We always have the options. Also, we get a lot of questions, can I add my own videos in there? So you can add your own branded videos into your own consult web-based database, and then show them as a pre-op, post-op, throughout treatment for different modes there.
Yeah. So That's the consult tab.
Right.
Thanks so much, Paul.
Sure.
With that, let's move to Sal, where he's going to be talking to us about the business side a little bit deeper and focus in. So James, if you want, I'll pass the helm over to you.
Right. So Sal, welcome aboard and thank you. You know, last week you worked with us. I think we've got your screen there talking more about the business of sleep medicine, either growing on what you're already doing at your office or finding ways to implement it and make this make sense for your office and your patients. Between you and Dr. Ataii, you've got a lot of experience in doing this, are the professionals. So Sal, I'm going to hand it over to you and thank you for joining us again today.
No problem. Yeah, and you know, I think the handoff here that we come from, which was, you know, the tools that are available to educate patients. When we talk about the business of dental sleep medicine, case presentation is probably one of the most important things, because if a patient does not accept treatment, you don't have a case, right? And if you're looking to monetize on and capitalize on the fact that we have a lot of individuals that may be suffering from this condition, your practice and your staff members have to become proficient at getting patients to accept treatment. And as I mentioned already, because the majority of patients are not going to be aware of how bad their condition is, it will take getting them properly educated. And, you know, cone beam is one way of educating your patients. And we're going to talk about other ways to also help paint that picture for your patients so that they can make the informed decision. I am, as Jim mentioned and Paul mentioned here, this is our second series. So if you missed the first one, we talked about the prevalency of the disorder. We also discussed the types of patients in more detail that fall into the category of sleep-related breathing disorders. But to give you a quick background on myself, I am the Chief Product Officer for Sleep Architects, but I'm also the Executive Director of the Foundation for Airway Health. And this is a nonprofit organization whose primary mission is to educate the public at large about the hidden dangers of unhealthy airways. And among some of my other responsibilities include being one of the 13 task force members for the American Dental Association that's establishing screening protocols to identify patients that are under 18. We have protocols for patients that are 18 and over, but we have yet to come up with a standardized protocol for children. And just to give you a quick stat, there's an estimated 54% of children that are mouth breathers. And that statistic alone should scare you, because that tells us that these individuals are not breathing properly. And if they continue on that pathway, they will become the adults that you're seeing day to day today with potential sleep-related breathing disorders. So as I mentioned already, a quick advertising regarding the Foundation for Airway Health. We do have coming up here October 2nd, we celebrate annually our Global Airway Health Day. And this year, we're going to have a 12-hour live webcast that will be provided to anyone that comes to our website. So we encourage all of you, there's no fees to participate. Encourage your patients to log in, globalo2day.org. It's going to be a 12-hour educational entertainment program geared towards bringing awareness to airway deficiencies. And given the coronavirus that's been impacting our society at large, the management of patients with airway deficiencies cannot come at a greater time than today. So let me get started then on the subject of how do you capitalize on this type of therapy? As Dr. Ataii already mentioned, especially right now with COVID, right, there's not only a lot of attention on the subject matter, but there's a lot of similarities between patients that are diagnosed or could be diagnosed with potential sleep-related breathing disorders and those that may be at risk of contracting the coronavirus. So what is the opportunity in your local office? To do that, and I've talked about this before, there's a research paper that was published in 2018 that shows that there's a global prevalence estimated to be approximately 1 billion people that suffer from obstructive sleep apnea. And if you overlay that with the amount of people that are have been compromised with the coronavirus, and this is again is a global pandemic, the numbers are still so much greater when it comes to this issue of sleep apnea. And that estimate of 1 billion people is considered to be understated. So to help you understand this, I want to show you this map that was published by the Centers of Disease Control, where they studied the sleeping disturbances amongst Americans during a 10-year surveillance study. And the conclusion of that study shows that at least 20% of adults suffer from sleep disturbances. In this map, what you're seeing are different colored states. For example, in California or in Oregon, where we have a white collar state, that represents that at least 21.8% of the adult population suffers from sleep disturbances. And as you look at some of the other states, the colors get darker because the prevalence is even higher, as high as 37%. So if you haven't heard of your patients asking you to help them or asking you questions about snoring or sleep apnea, you will, because more than likely someone in your own circle of family and friends, if not yourself, are also potentially suffering from this condition, because a lot of people have this potential problem. So from a financial perspective, you should know that at least 20% of the adult patients in your office are suffering from a sleep disorder, and this provides you with the opportunity to render a therapy. And our proposal is that you align yourself with the current protocols. The standard of care is to provide the patients with comprehensive management and long-term care, as opposed to the traditional model. The traditional model was the widget model, where a dental sleep medicine provider would offer the patient a sleep appliance and kiss them goodbye. And the new standard of care, the minimum that that patient should be under your care is 2.5 years. Now, for most of you in dentistry, you're like, oh my God, I got to see this patient for a long time. But you get reimbursed for every single one of your consultations, or you charge the patient for your consultations to manage them for that length of time. And the reason for this is that patients with sleep apnea will have to wear their devices for the rest of their lives. So minimally 2.5 years to ensure that the appliance is working as intended is the current standard of care. But in addition to the standard of care, what you have to your advantage is that there are market changes. The consumer at large has become aware of their sleeping habits. They have become aware because there's more news articles on this topic. There are best-selling textbooks that are being bought by the general population, such as the Arianna Huffington book on sleep. Most recently, James Nestor published a book on breathing, where he talks about sleep-related breathing disorders and how proper breathing is tremendous in helping patients with these conditions. And as Dr. Ataii mentioned, in 2017, the ADA also published an 11-point position statement asking all dental offices to actively screen and manage patients with sleep disorders. And as I mentioned already, the comprehensive patient management is a standard of care as published by the American Academy of Sleep Medicine, who is the organization that has oversight of the physicians that are involved in managing patients with these conditions. But for those of you that are interested in doing sleep or have done it already and are struggling with it, there are some realities that you're facing. So, some of you might be asking, how can I get started next week? The good news is that you can get started pretty quickly, but it is a journey. It's not something that, like a combing machine. You could buy the machine, get a little bit of training, and you're fully operational, right? And when it comes to dental sleep medicine, you have to enter a journey because you have to get educated, you have to get your team members educated, and then you have to gain the clinical confidence to not only properly select your patients, but to render the right treatment. And in our next presentation, we're going to talk about how to properly select cases, how to deliver appliances, and how to adjust them, because this is the part where that'll either make you or break you when it comes to dental sleep medicine. I also hear a lot that most of you feel that if you bill medically, that you might be committing fraud. So we'll talk about this later on today. And there's this concept in some cases where practices only want to collect the insurance reimbursement because in my local town, no patient has out-of-pocket monies to be able to pay me for services. So again, we'll talk about this today. And another question I get a lot is it legal to balance bill? So we'll demystify the concept of medical billing, because this is the number one reason why a practice either gets interested in doing sleep or falls out of wanting to do sleep because of the challenges that they're facing. And here are the possibilities. I mean, there's a good reason why practices are interested in medical billing, because you can get reimbursement like this one of $4,600, $800 for the cone beam scan and the consultation, for example, $7,500 for the appliance. These are actual allowables and reimbursements that have been provided for patients with sleep disorders. But you have to understand that, these are not all your cases, because when it comes to medical billing, there's what we call the insurance game. You have to understand what the insurance game is. And this is not an issue that is inherent only in the dental world when you bill medically, but it's also for any medical provider, whether it be a hospital or an individual clinician that's trying to bill medically for their treatments. They have to understand how to play this insurance game. So to better understand the insurance world, I've outlined here what the medical billing claims workflow looks like. You initially enter demographics of the patient that are going to be useful to submit a claim. You then contact the medical insurance company to verify whether the patient has benefits and what the benefits look like. And once you have that information, you can now begin to code your claim so that you could identify what diagnostic codes were selected for the patient during your evaluation of the patient, and what type of procedural codes you're going to be billing for to treat that patient. At this point, you're going to enter the charges into the system, and you now submit the claim. Up to this point, the easiest transaction is to submit the claim. Most insurance providers require you to submit it electronically, which takes basically the push of a button. However, the verification of benefits, now that takes a long time. It could take up to an hour sometimes, if not longer, to get the information verified with the medical insurance company. So this is where the frustration begins for dental offices, because you have staff members that are busy already, and unlike in the dental billing, they don't have as long wait times, and they could rely on electronic systems that could tell them whether the patient has benefits or not. Here, when it comes to medical billing, and especially when it comes to dental sleep medicine, you have to verify the information on the phone because there's no automated process to get this information. And here, once you submit the claim, now you have to go through the process of understanding if you're going to refund or provide credits to the patient, depending on how much money you were allowed and or reimbursed by the insurance company. You're going to do your payment postings. And this is where the biggest homework comes in, because now you have to follow up on claims. because it's not uncommon for the insurance companies to deny a claim or delay a claim because either they haven't received the information that they are requesting from you, or they claim they haven't received it, or the medical representative for the insurance company denies the claim, requiring more medical justification for you to explain why you want to treat this patient. So the follow-up is imperative because sometimes the insurance company only sends notification to the patient and doesn't even send any notification to the practitioner. So if your staff members are not actively following up, they're not going to be aware that there's possibly been a denial or request for information. And denial management requires team members that are able to dissect the reason why the claim was denied, appeal it, and overturn it. And that is the second most difficult aspect of medical billing. And in many ways, medical billing is intentionally made this difficult to frustrate the provider so that the provider gives up on wanting to get paid by the medical insurance company. And the medical insurance companies do a good job of selling their members with the idea that there's coverage, but only when it comes to providers that play by the rules of the medical insurance company, right? So claim submission is easy, as I mentioned. The verifications are very time consuming. The AR follow-up is even more time consuming. And what really makes or breaks the medical billing process is denial management and appeals. And to kind of highlight this difficulty in the medical insurance company or the medical insurance game, here's a quote by a commissioner of the National Association of Insurance that talks about, and in fact, she presented this in Congress, saying that the bottom line is that the insurance companies make money when they don't pay claims. They'll do anything to avoid paying because if they wait long enough, in some cases, they know that the policyholders are going to die. I mean, this is in the record. This is something that goes on day to day in the medical insurance world. Here we have Anthem Blue Cross recently got fined $5 million for failing to address consumer grievances. Anthem denied a submitted claim for a procedure, even though it had already issued a previous approval, for example, and it took 22 calls to get the denial and getting the attention of the proper representative. But even then, even after the 22 calls, the Anthem Blue Cross failed to resolve the complaint. Again, this is one of thousands upon thousands of incidents. But I tell you this not to scare you. I tell you this so that you're aware of what it is to do medical billing. And you cannot do dental sleep medicine without medical billing. I mean, yes, you can. You could do purely fee for service, but often your patients that do have medical coverage will ask you, why are you not able to bill my insurance company for these treatments? Because what you should know is that most insurance policy providers, most insurance carriers do reimburse for oral devices to treat patients with sleep disorders. You just have to know how to document your claim, how to bill it, and how to follow up with it to get reimbursed. And the other aspect of medical billing that becomes very complicated is the issue of patient responsibility and how it plays with our policy, right? Because at the end of the day, what matters to a patient is how much do I have to pay out of pocket, or this concept that, hey, I have medical insurance, so I don't need to pay anything out of pocket, right? That also happens. So you need to understand, and I'm going to quickly break it down here. We look at different health insurance plans, and you could see that what drives the deductible and the patient co-insurance is their premium. So the higher the premium, the lower the deductible, right? And if you understand the concept of deductibles, insurance companies kick in once the deductible is met. So for example, on an ideal plan, a patient with a deductible of $500 and a co-insurance of 10%, meaning that they will be responsible for 10% of the financial responsibility as a patient, that premium is at $5,000 a month. And if you have a premium of $450 a month, for example, your deductible goes up to $1,000, and your core responsibility might be 20%. Again, these are examples, but this is generally what happens. So the higher your premium, the lower your deductible and co-insurance. The lower your premium, the opposite is true. So when you look at that, here you're looking at a high plan example, right? The patient is paying approximately $350 a month, but you could see how that deductible is much higher, and the co-insurance is 50%. Why that matters to you is that if you verified benefits with a medical insurance company and it appeared that coverage was going to happen, the fact that the treatment is covered does not necessarily mean that you will get 100% of what you're billing reimbursed, right? It all boils down to the individual policy of that member and what their premiums look like against what their deductibles are, right? So I'm going to skip through this. And here's to give you an example of the types of reimbursements that you would get. So on a patient with a deductible of $1,000, where they have a co-insurance of 20%, if you're billing $10,000 for your treatment, let's say, the approximate patient responsibility is $2,100, and the insurance payment is $4,400, as an example, right? When the insurance company is allowing $6,500. And you could see then for some of these other examples, like the high deductible plan, even though the allowable is the same, the patient's responsibility is $5,200. You only get $1,200. Again, I could dive into a lot more detail, but this is just to give you a quick understanding of why medical insurance billing could be challenging at times. And one of the often questions I get asked is the subject of balance billing, because there's this concept that it is illegal to balance bill. So indeed, there is, for example, a state legislation that prevents HMOs from balance billing. And the genesis of balance billing law is related to ER emergency rooms, where an ambulance, for example, brought a patient on an emergency to a hospital, and within the ER, the patient is referred to an out-of-network provider, and the patients were having to pay these very large medical bills beyond what was being handled by the hospital. So this is the genesis of the law. But all of the laws that exist in America related to balance billing, and by the way, not every state has adopted these laws. We only have very few states in the nation that have adopted these laws, specifically talk about providers that are contracted with the insurance carrier. In our model that you're going to hear about today, we recommend that you never become an in-network provider with a medical insurance company when it comes to rendering treatments for sleep medicine, because this is part of the challenges that you're going to face. If you are contracted, you cannot balance bill, for example. If you are contracted, they're always going to negotiate rates that are less than ideal for you to actually be able to treat the patient long-term, as we're talking about. So there's a lot of disadvantages to becoming an in-network provider for medical treatment. This is, again, has nothing to do with dental. This is the medical side of the house. But again, I'm just going through these to show you that regardless of all of the laws, balance billing is only illegal if you are contracted, and it is not illegal if you are not contracted with the medical insurance provider. And most of the laws regarding balance billing are specific to ER-related procedures. So oftentimes, they're not even going to handle situations in your own office, for example. And on the subject of medical billing, the other question I get asked, as I mentioned before, is, hey, I'm a dentist. Why could I bill medically for these procedures? Well, to understand that, you should know that you are a physician, just like your other physician peers. The American Dental Association has already described you as a physician if you're a DDS or a DMD. More importantly, CMS guidelines, the Centers for Medicare Medicaid Services, also describes a DDS and a DMD as a physician. And that's important when it comes to medical billing because you are prescribing, for example, sleep studies where you suspect a patient that may be suffering from sleep disorders, and you're also going to bill medically for rendering a medical treatment for someone that has a medical condition such as sleep apnea, right? So this is with good reason that you should understand that you're a physician, right? Your scope of practice that has been adopted by every state act in America from this definition of dentistry doesn't only talk about the oral cavity, but it also talks about your responsibility of the adjacent and associated structures. So being a physician is imperative because you're able to then bill for not just sleep appliances, but you can bill for other appliances such as paddle expanders. For example, you could do extractions, stents, biopsies. The easiest of this list here are traumatic injuries. When a patient gets into, let's say, a vehicle accident, and any emergency care that you render, if they have medical insurance, that entire treatment could be billed for medically and you could get reimbursed. Of course, the exams and the consults and radiographs, cone beam, as I mentioned before, I showed you a reimbursement of about $800 for the cone beam evaluation of the patient. So there are some technicalities on how you bill properly for cone beam images. We'll talk about that here shortly, but the point is that there's a lot that you could bill for. And what does that mean to you? Well, what it means is that if you properly bill to get your patients treated properly, there are a few sequences that you have to do right so that you don't get denied or delayed. First of all is that you have to set appropriate UCR fees. Without setting usual, customary, and reasonable fees properly, whether you do it too low or too high, that could be a reason to delay or deny a claim, for example. You want to avoid in-network agreements, as I mentioned already. You want to get into the habit of collecting patient responsibility because, as you saw, medical reimbursement is not always going to be fully reimbursed. So getting into a agreement with the patient in advance is always recommended. You want to make sure that you outsource your medical billing processes because let me tell you, unless you have a big team, lots of resources to do medical billing, it's very difficult, right? Especially if you're trying to run your dental office and provide medical billing, medical services to your patients. So we strongly recommend that you find a partner that you could align yourself with and get medical billing done by them as opposed to your team members. And on the subject of team, you want to educate your entire team because, you know, patients are going to ask, why are you asking me for my medical insurance? Or what is my deductible? Or, you know, what did the insurance say? So your team has to be educated as well. But you have to be patient and don't give up because there is money that you can make. There are lots of reimbursements that could be paid out to you. You just have to know that sometimes the medical billing gain could take as long as 6 to 8 months to get reimbursed. But once you get the wheels turning, the reimbursements get quicker. And in some cases, you could get reimbursed within 3 to 4 weeks on average. So be patient, don't give up, don't fall in, and become victim of the game of the insurance companies. Because, for example, in 2016, the total U.S. spending on sleep apnea treatment here in America was $170 billion. So there are plenty of people that are looking for answers, and there are plenty of people that need your immediate attention. So you don't need to be leaving this money behind you. And, you know, because we are talking about cone beam and how useful it is for the purposes of clinical documentation and gathering the right information to do the right treatment plan for your patients, you should also know that cone beam could be its own financial center for you. It's a profit center if it's ran properly, right? Because you're able to get all of these amazing images that will help you justify why you want to treat the patient for sleep disorders. At the very minimum, the cone beam scan gives you an extra powerful tool to overturn a denial from the insurance company. And to get reimbursed for cone beam scans when it comes to airway management, you should know that you have to have a minimum field of view to capture the right anatomy so that you could have the medical justification to bill for your services. And to help you understand this, we talked about this last time, but here's an example where we show that over 99th percentile of adult males in America have a measurement, ramus to ramus, that is approximately 15.9 centimeters in diameter. So when you're considering using a cone beam image, whether you refer the patient out or if you buy a cone beam machine, make sure that you get a cone beam that is able to capture the condyles, it's able to capture the nasal cavity, and is also able to capture the oropharyngeal space all together, because your medical justification to render the scan on this patient is to analyze that entire infrastructure, and that's when the insurance companies will reimburse you. So our recommendation is that you have an appropriate field of view for airway analysis that is minimally 15 centimeters in diameter and 13 centimeters in height. And getting back then to the subject of dental sleep medicine, you know, your real currency is that you should become the hero to your patients, right? Getting patients and understanding that your real client is usually going to be the spouse when it comes to patients with sleep disorders. So to quickly go through the process of understanding what the patient, what the practice workflow should be when it comes to dental sleep medicine so that you could bill properly and get reimbursed. Let's look at this concept of treatment, right? Let's get away from the concept of widget and develop what we call a medically justified airway management protocol, right? And to do that, here are the 6 primary steps that you want to deploy in your office. You first want to screen the patient, and you want to, at that time, if you have a cone beam machine, establish a baseline cone beam scan of the patient. That's going to provide you with all of the clinical data necessary for you to justify why this patient should be provided with treatment at your office, for example. It's also going to help you build up your case for the purposes of case presentation. The next step is that you want to refer the patient to an overnight sleep study center, or you want to engage with a national provider that could send equipment to the patient's home so that you could get the patient's test, diagnosis, so that you may proceed with your sleep test, with your treatment. And a point of clarification, the cone beam scan is not diagnostic for sleep disorders. However, it is diagnostic to identify dental comorbidities. And when it comes to the sleep studies, only a certified sleep medicine physician could provide the diagnosis so that you could proceed to treat these patients that suffer from sleep apnea. Okay, so that's clarification there. And as I mentioned already, the collection of the initial records, which is going to be the screening form that the patient fills out, your physical evaluation of the patient, the cone beam scan, and the results of the sleep study, all of that gets put together so that when you recall the patient and you do a case presentation, you could at that time educate the patient so they could accept treatment. And as Paul and Jim showed you earlier today, being able to show the patient in real time what the airway looks like in combination with the results of the sleep study is a powerful way to educate the patient as to why they may be suffering from a condition. And don't let money get in the way of the patient's treatment. You're dealing with a life-threatening condition, so if the patient cannot afford to pay for the whole treatment, because they either don't have medical insurance or do not have the immediate funds, provide them with other financial options such as Care Credit or Green Sky so that the patient could accept treatment, right? And once the patient has accepted treatment, at this point, you're going to complete the examination and take impressions of the patient. And once you get the appliance back, you deliver the appliance. And at this point, we recommend that you do another cone beam scan. Again, this is going to help you build up your case, provide the patient with the long-term care management, and also allow you to properly bill for that case. And my last topic here is how do you then set your proper fees? To set the proper fees, again, understand that you're dealing with a comprehensive treatment regimen, right? It's not just delivering a widget into the patient's mouth, and that patient is going to be managed for about 2 years at the very minimum. So when you look at that, the widget model in America today is averaging anywhere between $2,500 to $3,500. The treatment model is anywhere between $5,000 to $8,000, depending on where you are in the U.S. So when you set your UCR fees, you should know that the fees have to be set according to the location where you're at. And usually you have to do a little market study that will provide you with the guidance on how to set these fees properly. And to look at these rates compared to the other options, here you're looking at what the average out-of-pocket responsibility is for patients that are getting treated with a CPAP machine, which is the gold standard, right? Or surgery as one of the options to treat patients with sleep disorders. Or if you offer oral appliance therapy for your patients, you could see that it's a very attractive option and alternative treatment that you offer patients that come to your office. And I show this because, again, oftentimes I get practices that say, you know, there's no way I could get a patient to pay me more than $2,500 for giving them this piece of plastic. Well, the reality is you're not going to give them a piece of plastic. You have to monitor and treat this patient minimally for 2 years, right? And if you do nothing, what happens? Patient gets a heart attack, and look at how expensive that is. Again, this is a published article on that feed. So your objective is to identify, treat, and manage your patients. And if you're looking to monetize on this situation, again, there's no better time than today when everyone is aware of the upper airway for you to screen your patients. You could do that remotely. You don't have to do it in person, and then take the patient through the next steps of getting their patient care. So with that, I'm going to turn it over to Jim and Paul so that we could open up the floor to some questions if we have some questions from the audience here.
Yes, thanks, Sal.
And by the way, and one thing I want to add is later on, after we're done with the Q&A session, I will provide the CE code so that for any of you that are interested in the CEs, you could get that.
Perfect. Thanks, Sal. Paul, do we have any questions coming through? I think we have a few on the docket there.
Yes, we do. Okay, so Brian is asking, can you comment on insurance denial? Oftentimes insurance companies won't tell you what's wrong on the insurance claim form. They also won't tell you the correct code to use to get the claim processed, is the question.
That's correct. Yes, pretty much they won't. They will provide, on the denial, the insurance company will provide you with a reason why the claim was denied, if it was denied for a lack of medical justification. They will oftentimes refer to parts of their medical policy, but not the entire policy, only sections of it, to justify why they denied the claim. And it would be your responsibility to ensure that you review the entire medical policy for that patient to confirm that despite their denial, everything that you've done has been completed under a medically justified procedure. And when it comes to the diagnostic codes and the CPT codes, again, this is why I mentioned, in my opinion, We don't recommend for any dental office to become proficient at medical billing. Provide that information over to a competent medical billing company, because they will have the expertise to properly code these claims and to submit them properly for medical reimbursement. But you're right, oftentimes the insurance company will not provide you with guidance on how to code your claim. That is correct.
Got it. Okay. Jerry, I have a question from Jerry. I have a smaller field of view device. Can I use my stitch images in regards to the insurance?
Yeah, generally, although I haven't seen any evidence of it recently, but in the past we have seen claims that were directly denied when stitch images were submitted for a claim. And not necessarily for the cone beam reimbursement. The claim was denied for treatment purposes because the image was distorted to a point where it was difficult for the clinician reviewing the record on the other side, on the insurance side, to justify how the clinician arrived at their conclusion that they billed for. So in those cases, we have seen cases where claims have been denied. Not only is it going to expose potentially your patient to overlap exposure, but the ability for you to maintain the patient's airway static long enough for you to capture a single image is already a difficult task in its own right. And when you have to split the images, it's only that much more difficult. And that's why, from our perspective, we recommend the wider field of use when it comes to patients with airway deficiencies.
Perfect.
Got it.
Sal, you have another question here. You talked about, bringing on, we'll call it a third party to assist with medical billing because it is very time consuming. Do you see offices eventually, once they, for lack of better terms, figure that out, moving on to doing it on their own? Or do they consistently kind of use the professionals to bring in the third party to save time and work with that in a medical billing aspect?
Sure. Yeah, I mean, I think it's important to say, I've been in the industry now close to 18 years. And I've seen, offices of all sizes and offices succeed at this game and others that largely fail at this game. And both, medical offices and dental offices that are billing medically for patients with sleep disorders. And I would tell you that largely most successful practices that are winning at this game outsource medical billing, but there are exceptions. We have examples of practices that handle all the medical billing themselves, and they're very successful. Generally, these offices are doing anywhere between 50 to 100 patients a month. So they have the financial resources to hire a large team that is only responsible for medical billing. And that is, ideal. But I've also seen the large number of practices that have failed at this game because they try to do it themselves. The staff members are just not equipped with the know-how, the time necessary to do it, or the skill set to properly appeal a denial, where this is where we see practices really not winning at the game, and why we, right out of the gate say, just be experts, as I said earlier, at identifying, treating, and managing your patients. And that's going to be one less headache for you to have to deal with. Most medical billing companies are billing proportionate to the claim in numbers that, in my opinion, are even less than what it would cost you to do it yourself. So that's why we recommend it. It makes total sense. And usually these guys are experts at what they do. They see more claims on a day than a practice ever sees in a year sometimes.
All right. Thanks, Sal. I do have a question, and I think this might be for Sal and Dr. Ataii. When working with patients that are on CPAP,
Mm-hmm.
and you're working with their general practitioners or their general doctors, family doctors, are you getting a pushback from the medical community of, oh, we need to stay with CPAP, or how does that work with working with the medical side?
Sure. I mean, at
I'll
least
go
from our perspective. Yeah, go ahead, Doc. Sorry, go ahead.
Well, I'll just tell you from a personal experience, the patients request it. So the patients request it and say, look, I'm tired of having this thing. And then they go to their doctor, and the doctor's like, well, I don't have any other option for you. Here's a different mask. And they try the different mask. They don't like it. And then they say that my dentist gave me an option. And typically, I'm glad to have Sleep Architect as my partner in the office. They start the conversation with the PCP, and we then at that point go through the phases of delivering oral appliance. So it's usually the patients who request it, especially nowadays.
Right, for sure. Definitely makes
Right.
sense because no one likes their CPAP, right? On there. One or two other questions, and I think these might be for the next session with you, Dr. Ataii. One of them is you had touched briefly on dose and scanning patients and the we'll call it the fear of the dose radiation. And I guess it's kind of how are you discussing dose with patients? But I think we're going to hold off on that one if you don't mind, and we can have that one for next time.
It's going to be a lot longer than just a quick answer.
Right on that. So, Paul, I think that's all the questions I saw come through. Do you have anything else that you've seen on the list there?
Let me just double check that. Brian is asking one more question here coming in. What do you do about insurance companies that insist that you be a provider on their dental plan before they will process a medical claim for sleep appliance? And conversely, that once you are enrolled in the dental plan, you are automatically enrolled to provide sleep appliances, often at a very poor price.
Yeah. Well, there's no requirement for you to be one way or another engaged with an insurance carrier, meaning that there's no law that forces you to have to be a dental provider before you could submit a medical claim. And if that happens, you have to take it up. We've taken claims all the way up to state commissioners, for example, and you get the state insurance commissioner to get involved or their office to get involved. And oftentimes taking claims up to that level will get the attention of the insurance carrier, and they will back off right away. Because for every claim against them that they get at the state commissioner's office, there's certain funding that the insurance companies get from states. Each one of these things reduces the amount of funding that they get. So they have currency against them if they choose to play these heavy-handed tactics. Again, it doesn't surprise me that they try to do these, wild, wild west moves on practitioners. But the reality is there's no requirement for you to render dental treatment as a dental provider in one program before you can now bill medically for a medically justified claim if the patient has benefits and coverage. The only thing that some insurance carriers may require for you to do is that you get into their system, but that doesn't mean that you become an in-network provider. All it means is that they want you to jump through hoops so you can add your name, your tax ID into their system before they reimburse a claim. But that's an administrative hurdle, not a contractual requirement.
Yeah, just to touch on that, it could be a confusing subject because your NPI, in my instance, I have a group NPI and I have a personal NPI. My group NPI is being used because I am out of network with all dental companies for the billing processes. So it could be a confusion that maybe the front office may be giving the messaging that they're expecting you to enroll to become in network, but there's absolutely positively no demand to do so. I've been out of network for over 22 years in my practice. And I'm doing fine.
Perfect. Thank you. Paul, I think that is all of our questions that we had come through.
That is. Thank you.
So part 3 next month, October 7th. Going to go delve a little bit deeper in the clinical applications of CBCT and sleep disorders.
So
Great.
I'll show, can you guys see my screen right now?
Yes, we can.
Oh, okay. I'm going to show then the CE code for today's session. And for those of you that are interested in learning more about sleep architects and what we provide, please include that in your notes and we'll have someone reach out to you because we, as a company, we're a turnkey solution provider. So we do everything from identifying the patient, helping you train not only yourself, but your staff members, and also do the medical billing for you. And we also provide you with a whole suite of FDA cleared devices to treat patients with sleep disorders. So with that, I want to thank all of you for attending today's course. Good night, good evening, good morning, if you're out of country, right?
And for all those who are watching this recorded, we do get a lot of people that go back and watch the recording. Thank you for your interest, and to everybody out there, you can find all of our sessions since April 1st on the Vatech website and the Customer Learning Center. Sal, thank you for your time. Dr. Ataii, thank you so much for taking the time out of your day and off your practice. We're looking forward to seeing you both again on October 7th. Paul, thank you again for co-hosting with me, and everyone have a great weekend and a great holiday at that. So thanks again and have a great evening.
Thank you.
Bye.
Okay, guys.